Give me great pleasure to welcome everyone to this webinar on COVID-19 and related health issues organized by the Asian Pacific Society of Cardiology, the Pakistan Society of Cardiac Society, as well as a seventh-day Karachi Adventist Hospital. Date stamp today is the 2nd of December, 10 a.m. Time in Pakistan, 1 p.m. in Singapore. My name is Dr. Jack Tan from Singapore, the current president of the Asian Pacific Society of Cardiology. Again, I'm very grateful for PCS as well as the Seventh-day Adventist Karachi Hospital in putting together this pertinent and very important webinar on COVID-19 update close to the end of the year in 2020. And we're almost 1 year post COVID-19. And it's indeed high time to get a quick update across a broad range of impact as well as clinical medical issues surrounding COVID-19. Today, the range of speakers will range from faculty from the US, UAE, Pakistan, as well as infectious disease, as well as cardiologists participating in this webinar. My co-hosts are Dr. Haroon Bakar Aziz, the president of Pakistan Cardiac Society, as well as Mr. Joshua Goh, the executive director for the Adventist Hospital, Karachi. So I'll welcome them to make an opening speech before I introduce the first speaker. Mr. Joshua Goh, please.
Thank you, Professor Tan. I'm Joshua Goh. I'm with the Karachi Adventist Hospital. Greetings, everybody, to this prestigious webinar. And really, it is our honor and privilege to host this webinar. We thank all the speakers and the collaborators and those who organize and put this together for their participation, for their efforts, and for the time, and to share with us the knowledge and experience that we've had in this worldwide concern in this COVID pandemic. So without having to take too much time off, there are more valuable presentations. Welcome, everybody. And again, we're thankful for your attendance here with us today. Thank you.
Thanks, Mr. Goh. So the chairpersons for today are Professor Ishtiaq Rasool, Professor Abdulla Shehab, Professor Feroz Memon, Professor Khalida Soomro, and Dr. Daniel Khan. So the moderator today is Professor Jiunn-lee, who's also organizing this webinar, live streaming it via the APSC TSOC cloud. I would like to just move on to the first talk of the day before we come back to the discussion led by the chairpersons. I would like to introduce the first speaker of today. His name is Dr. Roger. I don't want to mess with your last name. Seheult, is it? Seheult is an associate clinical professor at the University of California, Riverside School of Medicine, and an assistant clinical professor at the School of Medicine and Allied Health at Loma Linda University. So he's certified in internal medicine, pulmonary disease, critical care, as well as sleep medicine through the American Board of Internal Medicine. His current practice is in Banning, California, where he's a pulmonologist and sleep physician at the Beaver Medical Group. So without further ado, we'd like to welcome Roger to give us the latest 2020 update on the epidemiological data and public health measures that are impactful against the SARS-CoV-2 virus. So Roger, please.
Well, thank you so much. I appreciate it. Yeah, I'm speaking to you from not so sunny Southern California, where it's just after 9:00 p.m. here, but it's a pleasure to be there. I will say that Pakistan is in my DNA. My great-grandfather emigrated from Pakistan in the late 1800s to Trinidad, and so I do have a genetic connection there. But what I am tasked with is to talk to you about some of the epidemiological factors associated with COVID-19. And I couldn't think of a better topic in this regard than the topic of vitamin D. as we are starting to learn more and more about this, not only individually, but on a global scale. So I wanted to review with you real quickly what's going on with some of the data that we're getting regarding vitamin D epidemiologically. I have no interest to declare. This is kind of the outline that we're going to be talking about here for the next 12 minutes, so please bear with me. So vitamin D is neither a vitamin nor a hormone. It's really both. The thing that you've got to understand about vitamin D is it's a fat-soluble vitamin. Therefore, it goes into the receptor of the cell and actually has a transcriptional ligand that allows it to change the binding to the promoters and actually can affect transcription of genes. So that's a very important thing. The other thing you should know about vitamin D, of course, is that you can get it from the sun. That is the major way that you get vitamin D, but you can also get it as a supplement as well. And so that supplement is through vitamin D2 and vitamin D3. When it goes to the liver, it creates 25-hydroxy-vitamin D, as you can see here. And then it goes to the kidney where 1,25-dihydroxy-vitamin D, the active form, otherwise known as calcitrol, is utilized in bone metabolism. What you may not be aware is that 25-hydroxy-vitamin D is also used locally at the level of the immune system. And it can be converted there in a paracrine or autocrine way to affect immunomodulation. So vitamin D is very important in immunomodulation. Now, we did a study here in the United States, and I'll be using studies from the US, from all over the world here in the next 12 minutes to talk about what's going on. But specifically here in the United States, which is probably not too different around the world, we spend less than 7% of our waking moments or total time outside in the sun. Most of the time is spent either inside or in a vehicle. And so we get very little exposure now compared to about 100 years ago. That's very important because sunlight is the major way that we get vitamin D metabolism occurring. So major cause of deficiency is in exposure to sunlight. Also, it's inversely associated with BMI. And of course, patients with kidney disease can lose a lot of vitamin D3. So there's a lot of data that we've had prior to COVID-19 that showed that as you get older, you are more susceptible to vitamin D deficiency. Also looking at race, the color of skin, we can see this was a study that was done looking at 8,400 people in the United States and looking at Black, Mexican Americans, people who are darker skin. You can see very clearly that the darker skin you are, the more susceptible you are to getting vitamin D deficiency because it blocks a lot of that UVB light. Also, obesity is a major risk factor for vitamin D. You may recall that vitamin D is a fat-soluble vitamin. And so as you absorb vitamin D, it can get stored in the fat. And if it's not soluble, it's not available. And that's very important. Vitamin D metabolism, currently there's no international consensus about what optimal vitamin D supplementation levels should be. We know that supplementation with vitamin D leads to a reduction in fractures. It could be associated with a modest increase in heart attacks, according to some data. Targets around 30 to 40 nanograms per milliliter for fractures. If you get larger than 150, that can sometimes be associated with hypercalcemia. So what do people say? How much do you need? Some say up to 4,000 or even up to 10,000 international units per day. That's important even in places where you think you get a lot of sun. Here's a study that looked specifically at Pakistan. And they looked at 4,800 randomly selected citizens in Pakistan. And they found, according to this, that 54% had vitamin D deficiency. That's astounding. When you think about over half the population had levels consistent with vitamin D deficiency. So let's look at some evidence from prior observational and interventional studies looking at things outside of COVID. Here's a study that was really important in Germany, 10,000 patients. They looked at them prospectively over 15 years. And what did they find? Well, on initial examination of these patients, you can see that in the red, that was less than 30. In the 30 to 50 was sort of the orange, and then greater than 50 was in the green. You can see that at baseline, there's a significant amount of people in Germany who had vitamin D deficiency. Well, after following them for 15 years, they looked at respiratory causes of mortality. And what they found there is that there was a statistically significant difference between these subgroups. So we're looking at respiratory survival here. And you can see that vitamin D levels from 15 years ago could predict their mortality. And of course, here is the famous Martineau study that you may not be aware of. British Medical Journal looking at a number of studies, randomized controlled studies, and doing a meta-analysis showed for the first time that if you supplemented people with vitamin D about 1,000 international units a day, about 25 micrograms a day, you did it without bolusing them at low levels, particularly in people who were low. It showed that there was an improvement in mortality from acute chest infections. They said here that our study reports a major new indication for vitamin D supplementation, the prevention of acute respiratory tract infections. This was before COVID-19. I consider COVID-19 an acute respiratory tract infection. But don't stop there. Here's another trial where they actually supplemented school children with vitamin D over a winter. This is back in 2010. And they found that it reduced the rate of influenza A. Not COVID-19, but influenza A. And that was a major article as well. All right, let's talk about COVID-19, since that's what we're talking about. Very early on in this disease, we started noticing that the biomarkers that we saw with vitamin D deficiency were showing up with COVID-19. For instance, IL-6, elevated in vitamin D deficiency, elevated in COVID-19. Tumor necrosis factor alpha, elevated in vitamin D deficiency, also elevated in COVID-19. And the list goes on, like gamma interferon, Th1 adaptive responses, H2 expression, coagulability. What we saw is that COVID-19 is almost the same sort of phenotype as what we see in a vitamin D deficiency. But it didn't stop there, because we started looking at the epidemiological factors that we saw in COVID-19. And what did we see? We saw that as you got older, you had a higher risk of dying or getting COVID-19. As you had increased obesity, that was an increased risk factor for COVID-19. As you had darker and darker skin, that's hold true that you had a higher rate of having COVID-19. And these three factors, age, obesity, and ethnicity, are the same factors that we showed at the very beginning that we've known for years are associated with vitamin D deficiencies. So it begs the question whether COVID-19 is really associated with this. So more studies were done, and we started looking at something very interesting here. We started looking at degrees from the equator. We know that as you move from the equator, the sun, you get less hours of sunlight. And we were plotting out based, if we took all of the other associated factors out, we could see very clearly that as we move away from the equator, mortality rates went up in COVID-19, with the highest ones being Belgium, the Netherlands, Sweden. Interestingly, Finland is not on there, by the way. Finland supplements its population with vitamin D. It fortifies that as part of their population. That's a very interesting finding. There was another study that looked at the cases of COVID-19 per million population. And what they found there was an inverse relationship on mean vitamin D levels in the population. So the higher the vitamin D levels in the population were, the less likely they were to find cases of COVID-19. Same thing went for mortality per million population. The higher the mean vitamin D concentrations were in the population, the less the chance of them having mortality per million population. All right, let's talk about what about actual infections. Here's a study that was done not in Europe, but in the United States. And what they were able to show was something very similar. We're not talking about COVID-19, we're talking about SARS-CoV-2 positivity rate. In other words, what's just the likelihood that you're going to get infected with SARS-CoV-2? Again, inverse relationship here, very clear in terms of vitamin D concentration. You can see here around 50 was where it took. Anything below 50 and you started to have an increase. By the way, this cut the same way whether it was in the northern part of the United States or in the southern part. Obviously in the southern part where there's more sunlight, there was generally a lower level, but it's still the same relationship. Same relationship with age, same relationship with sex, same relationship with race. This cut across all the lines. All right, what about course progression? Here's another study that was done here in Germany once again, and they looked at the patients' vitamin D levels, and they looked at their ability to survive COVID-19. And you can see here very clearly that when you looked in red at those people with vitamin D levels less than 12, that's really low. They had a horrible survival probability versus those that had greater than 12. Here again, they did it at 20, and those that were less than 20, horrible survival versus those that were greater than 20. All of these things are associated, but you have to realize that when you come to association, that's the first thing they teach you in medical school, right? Association does not necessarily mean causation. A lot of things can be, for instance, I've got patients that get lung cancer, and guess what they all have? They have a cigarette lighter in their pockets. They got a cigarette lighter in their breast pocket. Well, cigarette lighters in the breast pocket are associated with lung cancer, but they don't cause lung cancer. Putting a cigarette lighter in your breast pocket doesn't cause lung cancer. Smoking causes it. So we still have not completely made that connection. The way we do that is by supplementing them with and doing a randomized placebo-controlled trial, as you all know. So here's a study out of Spain that took patients that were randomized to, or actually, there was not randomized. This was a consecutive patients that were given calcifediol. Now, what's calcifediol? Calcifediol is the 25-hydroxy version of vitamin D, and this is what is metabolized after it comes out of the liver. And so what they did was they treated one group of 50 with calcifediol, high doses on the first day, on the third day, and the seventh day. And the second one was without calcifediol. Now look at these numbers here. 50% without calcifediol went to the intensive care unit. 2% with the calcifediol went to the intensive care unit. So this was a pilot study. It's going to be reproduced. They're going to do a larger study to see whether or not this holds. Here's an interesting study from Germany. Now, in Germany, in the nursing home, everybody's supposed to get 80,000 units every 2 to 3 months of vitamin D. What they did was that when they admitted these patients from the nursing home, they looked back to see whether or not they had gotten their shot recently or not. Those that had gotten their shot recently in the last month are on the red line here. They have survival probability that is very, very good. Those that got their shot in the last 2 to 3 months had a worse survivability. So it's kind of a quasi-experimental study recently published. Very interesting. Here's another study, this time out of Brazil, where they gave 200,000 international units of vitamin D when the patients came into the hospital. Here, they did not notice any difference whatsoever in the groups. They did note, though, that those that got the injection had higher levels, but it did not seem to make a difference in this case. My criticism of this one was that they only received one dose when they first came in. We know antibiotics work in infections, and we never give one dose of antibiotics. So I would say I'd love to see this being given more often. And then here's another study that was just recently published out of India called the Shehab study, just published in India. And what they showed was when they gave 60,000 international units orally daily for 7 days, that by day 21, the intervention group had 62% SARS-CoV-2 negative, whereas those that didn't get any vitamin D supplementation, only 20% went SARS-CoV-2 negative. And also in the intervention group, the fibrinogen levels were significantly lower. So what's the call to action? I would say epidemiologically, when we're looking out there and we're seeing who's getting COVID-19, that vitamin D should not be overlooked, that you should be getting plenty of sunlight exposure. That's the best way to get it. If you can't get that, especially in the wintertime, if you live at very northern or extreme latitudes, then to consider very highly considering a supplementation regimen. And I'll just read this for you and then I'll be done. This is a study out of Ireland, which has a lot of issues with sunshine exposure. It says Ireland does not have any formal vitamin D policy. You practice a voluntary but not mandatory food fortification policy where food manufacturers can decide to fortify or not their food products with vitamin D. The vitamin D status of those in Ireland is lower than either the United States or Canada, who have a mass vitamin D fortification program. However, vitamin D deficiency is not inevitable in older adults in Ireland, and the ability to have sufficient vitamin D status year-round is an achievable goal that many countries meet. For example, another European country, Finland, which is at a much higher latitude and therefore receives less sunshine than Ireland, has virtually eliminated vitamin D deficiency in its population with rates at less than 1%. And that's because of food fortification. And I might point out to our guests and those that are joining us that if you were to look at Finland's rate of SARS-CoV-2, it is probably the lowest of all the Nordic countries. and an example, not just for food fortification, but also for other practices. And for that, I apologize on my slightly going over time, and I think we're open for questions.
Thanks, Roger. That was fantastic and very interesting. I did send out a query to some of my colleagues on the vitamin D data and COVID-19, and the reply is still in research phase though, and there's some queries. So I'd like to welcome my chairpersons to help moderate and ask questions for the session. Professor Rasool, Professor Abdulla, Professor Memon, and Khalida, as well as Professor Khan. Any comments or questions? Yes, Feroz, you're muted. Can you unmute yourself first? Yeah, go
right.
ahead.
Good afternoon, everybody. It was a pleasure. It was a wonderful talk. Now, what we thought to believe is that it's the sunshine which is giving us vitamin D, and we are very happy that we have got a lot of sun around. But now what are we told today? That your color, the skin, and the sunshine will not do the job unless you are really fortified nutritionally with vitamin D. I think that's a very good knowledge, and that's what we would keep on telling to our patients now, and we have to educate our patients and our population and make them aware of the nutritional value of vitamin D. I think that is very important, and has been proved beyond reasonable doubt that vitamin D do help in COVID treatment. Thank you very much.
Thanks for the comment, Feroz. Any other comments from the chairs or anyone? If not, I actually, when I asked this question of my colleague 2 months ago, I was looking at the benefits in terms of cardiovascular outcomes as a cardiologist. And I think there's evidence to suggest that screening, replacing prevents fractures. But I must say the data even there is a bit mixed in terms of preventing fractures in only nursing home inmates rather than across the board. But can I ask my infectious disease colleague, Dr. Laxmi, what is the take on vitamin D and COVID-19? Should we be giving everyone vitamin D? Regardless whether you should check the levels in the first place? I think Dr. Laxmi is not in. Roger, will you advocate checking the levels first before replacing or just giving it anyhow?
You know, it's a good question. At my hospital, it takes me about 3 or 4 days for me to get the levels back because it's a send out exam. So in anybody that's coming in symptomatic with vitamin D, with COVID-19, I'm giving everybody, based on that Indian study, the SHADE study, I'm giving them 50,000 units of vitamin D orally daily for 7 days. I've never seen a vitamin D toxicity from that. I personally am taking 5,000 units a day of international units a day. And I live in sunny Southern California. And I'll tell you, I was taking 2,000 units daily and I had my level checked and it was 48, which is reasonable, but I'd like it to be, between 50 and 100.
Can you share with us what is the level you think will be protective based on the data that you showed?
It's all over the place. I saw one study that they recommended 75. I saw another study, you saw that curve that we showed where it was sort of came horizontal at around 50. And then we just showed that one study where they compared the survival rates at around 20. So I don't know what's a good level. I would say personally, based on the data that I've seen, if you're somewhere between 50 and 100, I think you're probably in good company.
Okay, so there's a question though. At what level of vitamin D deficiency, if you do screen for it, should you start replacement therapy?
Yeah, so that, like we were just saying, I would say if you're below 50, especially in this COVID pandemic, and especially now that we're entering the winter time in the Northern Hemisphere, for those that are living, between the tropics, probably doesn't matter as much. But if you're living, I believe they say north of the 35th parallel, which is sort of a line that runs right through the middle of the United States. If you get a globe and sort of trace that around the planet, you're at risk for getting vitamin D deficiency during the winter months. And my recommendation, this is what I'm doing, is taking 5,000 units a day, at least during the winter months.
Any other questions from the panel? If not, maybe I can just highlight again some disclaimer. The opinions expressed in this webinar doesn't necessarily represent those of APSC, because I think vitamin D deficiency in those studies have a lot of confounders. A lot of vitamin D deficiency patients are predominantly elderly as well. So I think if you do screen for it, even in sunny tropics, a lot of elderly patients do have vitamin D deficiency, and they probably would benefit from replacement. Whether it does reduce infectivity or severity of COVID-19, I think I would still prefer to see more data, a more bigger set data than, for example, the 40 patient study from India. Any other comments?
Dr. Tan, I was just going to mention, it's interesting to me. I agree, we need more data, and they are going to give us more data. One thing that I found interesting is that COVID seems to rip through, at least in the United States, nursing homes. That seems to be the real problem. And I can't think of a population that's more at risk for not being exposed to the sun than these nursing home patients. The other thing I was going to mention to you is historically, at least in the United States and many other countries, tuberculosis sanitariums were always at very high altitudes. And the thought for that was initially because lack of oxygen seems to be a necessity for killing tuberculosis. But the other thing that they're starting to realize is that as you go up in altitude, the amount of ultraviolet B radiation increases dramatically and vitamin D production goes up.
Okay, there's a question about different geographical regions. Is, for example, sunny Southeast Asia or East Asia different between that and North American and European countries? And if you do get COVID-19 currently, how many days or what dose of vitamin D are you advocating?
So we showed that study that showed that over 53% of people in Pakistan were vitamin D deficient. And so the people that you're going to actually see this with are those that are industrialized, that are living inside roofs and going to work. These are the people that are not exposed to the sun. Unfortunately, that seems to be the problem. As you become more industrialized, you disappear from the sun. And so you don't get that ultraviolet radiation. Again, if in patients who are being admitted for COVID, what I am doing based on the SHADE study and basically to make sure that we're not over giving them vitamin D is I'm doing 7 days of 50,000 units, international units. There was no adverse events in the SHADE study that was published. So I don't think you're going to harm your patients by giving them 50,000 units of vitamin D over a 7-day period. Remember that it takes some time for the liver to metabolize the vitamin D into the 25-hydroxy vitamin D, which is sort of the thing that you're actually measuring when you measure vitamin D. So remember that you're measuring the 25-hydroxy vitamin D, which is the product of liver metabolism. When you take oral vitamin D supplementation, the liver still has to convert that to the 25-hydroxy form.
Thanks, Roger. Is there any other comments or questions from the panel or the co-chairs?
Morning, how are you all? This is Dr. Bilal Mohyuddin from Pakistan.
Welcome.
Just joined in later, and when the vitamin D is all being flowing around. And Roger very kindly commented on Pakistani population, etc. And I know we have this part of the issue. But Roger, would you like to comment on a fact that an outdoor sportsman who's a professional sports person and is a cricketer? So you know the cricket is a sport which is played all outdoor and in the sun hours. It's not played indoors at all. And he moves around fit as a fiddle and his levels are 15 and 20. So what is your take on that? And these are professional sports people, and I've seen a couple of them across the board in our part of the world. What's your take on that?
Yeah, I mean, there's a Gaussian distribution of vitamin D levels for any given weight, age, and gender and sun exposure. So there are going to be people at both ends of that. It's something that we've got to investigate. There's probably other factors involved, but again, the big one. I mean, I don't have an explanation as to why his would be 15. That's pretty low, but it is certainly. I mean, if he's very dark skinned, he might not be getting as much absorption and he may need to supplement. But That's the best data that we have.
Well, as the people may like to believe that we Asians are dark-skinned, not all of us are. And this gentleman, a couple of these young boys that I see, in our part of the world, being fair-skinned is sign of purity and sign of beauty. So people like to be on the fairer side. And if you see Professor Feroz Memon also sitting over there, you'll notice that he's also quite a fair-skinned person right over there. So what I'm thereby saying, and again, Dan, as you can see, my only take on this so far as a cardiologist, etc., is that like vitamin E, like coenzymes, which have come in, became a fad, then have had their downfall, etc. So I'm rather skeptical on all of this. And yes, they do say it makes a difference. But when these young boys who are fantastic athletes, and even those elderly people who are great athletes, and they're playing golf all the time. And their query always is that, look, I play golf all saras, even in summers for that matter. And we have got some crazy dudes over here who put a wet cloth in the month of June on top of their head and are playing golf at 120 degrees Fahrenheit outside. So, and yet their vitamin D levels are low. So I'm totally, confused. I really can't put my finger and say, this is the right. So your 50 over here actually holds around 25. So is this a north-south, is this an equatorial kind of an issue? I seriously don't know, because a few friends I've got down in that place called the Yellowstone, right up in Canada, and Yellowknife, and his levels are also on a different level. So he takes his medicine because he has been prescribed so, but my answer is totally different. I really don't know the answer. And as you yourself said that you don't have the explanations either. So I only hope we're not playing in the hands of the industry.
Well, I don't know if there is a vitamin D industry. It's the best way to actually get vitamin D is just to go outside into the sun. That's the major way that we get vitamin D supplementation. So the answer here is that it's free. And what you need to do is go out into the sun. I mean, when animals get sick, they go into the sun. They know what to do. So this is not, I have no ties to any industries or anything like that. And I'm not saying you think I do, but really the answer here is just sunlight, fresh air. These are the things that we used to do many years ago. And now we've gotten industrialized. We spend very little time outside in the sun. I mean, we looked at a study here in the United States where less than 7% of our waking hours are spent outside. So I think there's some real benefits from the ultraviolet light. I think the dermatologist would probably disagree with me, but I think there's a happy medium.
Yeah, if you look into the old literature, the George Orwell's book Up and Down the Streets of Paris and London, and that's exactly probably he at that moment, being a literate, was talking about. But anyway, that's a different battle altogether.
Thanks a lot for those comments. So I think we'll use up the time for Q&A. We're going to move on to the second talk of the day. It's giving me great pleasure to introduce my friend and colleague, Professor Abdulla Shehab, the Vice President of the Gulf Intervention Society, Editor-in-Chief of the New Emirates Medical Journal, Professor of Cardiovascular Medicine, Chairman of the Arab Board Cardiology Fellowship Training and Examination Committee, and blah, 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 many, many, many more. It's like, I don't want to spend the time doing a lecture on his CV. So without further ado, I welcome Abdulla to give us a 12-minute update on the cardiovascular complications of COVID-19 and the management in a quick lecture. Thanks, Abdulla.
Thank you very much, Jack, and thank the Pakistani Society of Cardiology and everyone involved in this, I think, an excellent meeting. So in this few minutes, I'd like to share with you some of the, things been happening in the past. This is, as they say it, we all COVID doctors. I think during this time, everyone learn from each other. There's no hierarchy of, I am the boss. I think everyone at the same level. I think that should be the leadership during the crisis. So no conflict of interest to this. We all know this started from China, and this 2019. It's called COVID-19. And as Fauci said, this is more than just a common cold. And some of us still think of common cold, because if you look in UAE, for example, we've people infected by COVID is around 170,000, and the death is 560. That means the percentage of who've died from this is almost like 0.3. You can say it's like a cold, isn't it? I mean, and if you look at the number being infected in total to the population is, we are at 10 millions. So that's again 1.5 being infected with this virus. So it's very, very low. Everyone in UAE being tested for by the way, for PCR. And I think, we have a great control of this, of the disease. So this is the beta COVID, we know that. And it's mainly the exposure to the droplets, although the people say through even that's why the mask is everywhere. And that's the measure we take, all of us. I think this is the best way to protect ourselves. Even the vaccination, I don't think is doing the efficacy as what this measure does. The symptoms, and we're all aware of it, is non-specific. We don't know, it could be anything. The good thing is that majority of these get infected are mild, some being not noticed. The severe and the critical one are very rare, and so in general the mortality is very low. But if you come to the people with coexistent cardiovascular or respiratory or other diseases, then that increases, as you can see here, as says 10%, but I think it varies from country to country, but this is coming from China again. The waves, they talk about the waves. We all had lots of patients in our hospitals, in our critical hospitals overloaded at the beginning. But I think most of us now, I'm hardly seeing anybody coming to hospital with COVID nowadays. We used to see ST elevation, stroke, all that associated with the COVID, but not anymore. I don't see them at least in UAE. We all learned about the viral response and host response as it could be a theory. We don't know. It's just people all learning. Nobody can claim they know everything about the COVID. It's what we say today. Yesterday, it's all disappeared now. There's something new. Protocol changed. I think the guidelines, everyone had input to this, but I think everything is changing. I think it's a moving target. These are the associated risk factors. If it's there, then the mortality is high, and then it's a multi-organ, like any other infectious, affect every part of the body. And this ACE2 is available in, I think, lung and the heart and the kidneys and they call it endothelial. So everywhere, every part get infected. So back to cardiovascular, who are at, if they get it at more worse outcome, those who are the male, unfortunately, advanced age, diabetic, hypertensive. We used to think it's obesity, but overweight is the problem. If you look at the data, is mainly overweight are get the worst outcome, and patient with established cardiovascular disease, of course, and cerebrovascular disease. This recently published and tells you about the presence of underlying cardiovascular comorbidities in patients with COVID-19 associated with increased mortality. COVID-19 can cause acute cardiovascular complications, which include myocardial injury, arrhythmias, acute coronary syndrome, thromboembolic diseases. And if you look at the percentage of people get the problem with the cardiovascular are small, but but when you come to the outcome is the worst. So it's like if you have a cardiovascular disease, the severity of the adverse outcome is like 21% odds ratio. How this happens is through the theory, as the people say, by experimental, is through the ACE2, and is available in the lung and the kidneys and the heart. And of course, we are, as a cardiologist, we have some simple way to assess patients, and we do through the ECG and chest X-ray, bloods, as you can see there, and also, of course, the echo and the coronary angiography. And these are the complications, and just in one page, so we range from acute coronary syndrome to arrhythmias, could be with medication, or directly without medications, and cardiac shock, cardiac fusion, thrombotic complication, and direct death. So as already mentioned this, at the beginning, we used to think ST elevation coming very late to us, but coming with a big complication, like 40 years ago when we used to see the ST elevation complication coming to us because of the already taken 24 hours, 48 hours to arrive to us with all the complication of the with the myocardial infarction itself, rather than just the infection. So the delay, and then of course the ST elevation, of course, they were presentation more at the beginning, but the management, again, as you heard, is changed from place to place. At the beginning, don't do primary PCI in these patients, just thrombolysis, but then the guidelines change again, or go back to what we used to do, and even the stent thrombosis, of course. So how this happened, we don't know. I think when they say talk about type 1 myocardial infarction, which we know is due to rupture coronaries or erosions, we know that. But when it comes to the myocardial type 2, that could be to hemodynamic, could be to some direct viral insult. Tachyarrhythmias, the similar, is due to the adrenergic stimulation, cytokine storm. So many theories there. So an example here of a patient, you can see a young patient presenting with ST elevation, but if too much thrombus in this patient actually, and we just put a wire and everything open. So of course we didn't do the IVUS in this. So we can see is too much thrombus in a young patient without any risk factors before. So as most of these patients had lots of thrombogenicity of these or more thrombin than anything else. If you look at their bloods, you can see like NT-proBNP is very high in these patients. And I've given an example here, but of course, majority of we've seen is like that. And the dimer is very high. Of course, when you see something like this, the outcome is normally is bad. But those with the lower D-dimer, lower NT-proBNP and troponin, the outcome is much better. Similarly, a patient here we think is, ECG looks not bad to start with, but chest X-ray is suspicious because these patients sometimes tell you, no symptoms, but if you look at the chest X-ray, there are some discrepancy between what they say and you find, and this patient was actually changing in ECG, and was most likely to have again, this patient with proximal mid LAD, and that was treated successfully. Cardiac injury in patient with COVID-19 complication varies from 10 to 28%. Again, depends where they are living. If the patient's in this part of the world, lower than that. But I'm going to show you the across the world. It varies from 1% to 100%. And how this happened, again, I already mentioned to you. So this is the graph I mentioned. So it varies from 1% to 100%. Depends what the study, what sample they used for their report. These are the things which is mimics STEMI. That's why it's very important to do coronary angiography. When patient comes to you with a ST elevation, you don't know if this is really true type 1 or type 2 myocardial. I mean, you look at their arteries, looks normal, but they have Takotsubo, they have mycarditis. And again, it's difficult to tell mycarditis unless you go through the definition of mycarditis. You need to have a tissue, or you to have an MRI. It's not that easy. So, but you have to exclude, of course, the obvious. So that's a summary of the mycarditis, and then the heart failure. Again, we have many types already mentioned to you. These are the other complications. Could be from myocarditis to Kotsubo. I already mentioned that to you. And the way that's happening, either these are all theory. We don't know. This is all still we don't know. We are learning. It's again, it could be through the ACE2 mediated direct damage due to hypoxia, due to viral directly affecting this, or due to cytokine storm. Each of these, of course, needs a lecture itself, but these are the theory behind the way it's myocarditis and heart failure happening in heart failure patients. Some examples mentioned, and reported, the patients coming, normal coronaries. These are the type of the mycarditis I mentioned, which is very adverse, very gray outcome, and even the death. The higher the troponin, the higher the risk of the death. It's a cytokine storm, of course. It's again, there are lots of lectures about it. This is where, when this happens, you try every cocktails you have, even the vitamin K, I think, vitamin D, sorry. So the ECG and arrhythmias, that could be, as I said, due to medication itself or due to the viral, and that's I've not seen, actually. They said about chloroquine and hydroxychloroquine. I've not seen it here in UAE, but these are the things you expect from atrial to ventricular arrhythmias to death. And of course, the management should be, again, directly to control the life-threatening arrhythmias the way we do normally in our management. And these are the mechanism behind the arrhythmias: myocardial injury, antibiotic, drugs, lung injury. So we've seen it in these are some examples of the ECGs. You can see the ECG doesn't look normal. If you look at them, this is somebody's ECG normal before and become like this. Is it due to coronaries? Is it due to myocardial? But this patient got mycarditis, similar to this one as well. What about thromboembolic events? I mean, this is the most of the data now about the thromboembolic events. Either the stroke or massive pulmonary embolism, as you can see here. And of course, the outcome is very bad and very poor when this happens. So these are just the one page again to finish and tell you, that these are the complications we get: arrhythmias, thrombotic events, coronary events, heart failure, and death. So comorbidities, patient with COVID, it's very bad when this happens. So we try to prevent as much as we can patient with cardiovascular disease not to get infected with this COVID, to have all the measures which I mentioned at the beginning. And when this happened, of course, we have to intervene as early as possible. And again, you have to have a index of suspicious always of any medication we use during the COVID. As I said, is a moving target. We are all learning. We are all students. We have to stay like that. And thank you very much.
Thanks, Abdulla, for that succinct summary of clinical manifestation, particularly cardiovascular in COVID-19. Any comments, questions from my chairs and panel? So it seems as if the UAE believes that this is a little bit more than common flu in terms of mortality rate. You quoted 0.3%. Is that correct, Abdulla?
It's not a belief, Jack. It's what the data shows. Data tell us, it's almost like that. So the mortality is 0.3 here in UAE. And we've done tests to everyone. Everyone in UAE, 10 millions almost had that test. So 570 died so far, and infected 170,000.
Any other comments? Anyone want to give a take on that figure? Roger, your pulmonologist, is that the figure coming out from the States?
Yeah, I would just say, I mean, I don't know exactly how far away the UAE is from the equator, but I imagine it's not very far. And that would go along with what the studies have seemed to indicate, that the farther you are away from the equator, the higher the mortality is, unless you have a sustained supplement of vitamin D. I hate to hit that vitamin D bell over and over again, but it's not surprising to me that the mortality rate in the UAE is so low.
What is the mortality rate in Pakistan? My colleagues in Pakistan.
Well, Pakistan has a population of about 220 million, and give and take a few thousand, I presume. And so far, we have lost less than 10,000 people, documented wise. Some people may come up with the opinion that, yes, we do not have enough documentation going on, etc. We are not that rich that we can offer testing across to everyone, but we are doing whatever we can. And For us, the mortality is not that bad, but the basic fact that we are so many and our resources are so thinned out because of so many other reasons that we do face certain challenges. But we are lucky, and our main belief is that unlike USA, our main action was that we went into a lockdown very early, and we started controlling the mass gathering areas very early. And that's also what UAE did a lot. And we started introducing travel restrictions and all of those things. And our belief is that apart from the magnanimous support given to us by the Almighty Allah subhanahu wa ta'ala, it was these few things that we did, and out of them, this was one fact. And then, of course, we really marketed the concept of wearing the masks and social distancing and hand washing. So these things did make us some difference. Then, having said that, another difference in our part of the world is that nearly 70 to 80% of our population is from the rural backgrounds. So the rural backgrounds automatically has those free spaces and well-ventilated areas. We do not have the central air conditioning systems that a lot of these developed world and even UAE has. So again, we are not privileged to have the HEPA filters everywhere going around. So they cut down on these air conditioning plants, etc., and that made some difference. So all of these things did sort of contribute into it. And yes, you may say that the environment does make a difference. We do have this second wave coming in quite very well over there. But as far as internationally, the numbers are concerned, in population-based, Pakistan is quite privileged that we are quite low as far as the mortalities and even the hospitalizations are concerned.
That's great to hear, actually. Any other comments from the faculty?
I was going to comment one thing there, Dr. Tan. Another thing, again, vitamin D. Good data that shows that the amount of fructose in the diet I know biochemically that fructose can inhibit the 1-hydroxylation in the kidney of vitamin D. So if you look at fructose in the diet, high fructose corn syrup is what I'm getting at. That if you correlate that, the single biggest consumer in the world in terms of country of high fructose corn syrup is the United States. I think the second one is less than half of that. And so diet, I also obviously plays a big role in that. If you look at the Western diet, soda, if you look at sodas that are sold in the United States, they use almost exclusively high fructose corn syrup, and that has to do with political things as well. If you go and buy the same can of Coca-Cola in Europe, it will actually be sweetened using cane sugar. So that may have some interesting applications as well. And of course, we all know the issues with sugar intake, carbohydrates, and BMI, and how that's related to COVID-19 as well.
Thanks, Roger. There's two questions for Abdulla. One is, what are the other causes of arrhythmia apart from AMI in patients with COVID-19? And is there any impact on MI incidence in younger women in reproductive ages? Abdulla, any data from your side?
Sorry, the last one was what? Sorry.
In ladies who are younger in the reproductive age, do you see any MIs in younger females as well due to COVID-19?
I mean, I have not seen really in that age, but we have a registry in acute coronary syndrome, but not in COVID. In young patients, but not in COVID patients. But the first one, the arrhythmias, as I said, that we've seen it as association, post-MI, I've seen it, with heart failure, I've seen it. But again, I cannot really say directly due to the COVID, but these are the normal arrhythmias we see, like atrial and ventricular arrhythmias, and but the one mentioned associated with the hydroxychloroquine, I've not seen it. In UAE, we've used. I think we used it very in a high dose even, at the beginning because there was no protocol. But I've not seen. None of us came across that. It's mentioned that.
Any other observations on the rest of the faculty? If not, actually, I think we have to be aware that COVID-19, like any other virus, can cause like viral myocarditis. And that's probably the most common cause for other arrhythmia non-MI related. They can be fulminant as well. Fulminant myocarditis is one cause. Minoca, stress cardiomyopathy, all these are the other causes if they are critically ill. And of course, you have to be aware that they can get a massive PE as well. So I'm going to quickly introduce the next speaker, and I think the two topics are quite related. So we're going to have Professor Bilal, who's a professor of cardiology at the King Edward Medical University and practitioner at the Mayo Hospital, Lahore, Pakistan. He's going to talk to us about clinical manifestation of COVID-19 and its outcomes. I think these two topics are probably quite interrelated.
You got that right. So you cannot, well, other participants still sharing screen, so I think that needs to be taken off first. Have we got it done?
Yeah, I've stopped sharing. So please go ahead.
And okay, do you have it?
Yes, but we probably need to...
Can you see it?
Yep, we can.
Great. So firstly, let me thank all the friends across the globe. People are sitting quite far and away and in these trying circumstances. And thank you for the organizers and the team for organizing this thing and getting me into it. Gave me an opportunity to sort of patch up on what it is. These are my disclosures. Some of these slides were borrowed out with permissions, of course, and my university has helped me a lot into it. No conflict of financial interest and nothing else to be disclosed. So this much we know, that it's an aerosol, suspended airborne molecules, and it doesn't have a mosquito like sort of lots of other diseases carry in between. And there's no other, and it's just from one person to the other person, and that's why we need to keep our adequate distances there. We also know very well that the patients coming in at around the fourth day, mostly they had the problems of cough, fever, shortness of breath, and these were the cardinal complaints that everyone was coming. But down the road, if you look at the end, you have even ear pains and conjunctivitis, but these were all over there. So, dividing up the whole pandemics into its various places, how to look at it? Well, you have the symptoms, yes, but if you have a simple pulse oximeter going around, and if you're maintaining your oxygens well above 97, 98, so you can be probably in the mild group. If you're around 95, 94, 95, you are on the moderate. And if you're getting in the severe, that is now you're going below 94. Now, this is one point that I really want to highlight over here because few people that I know of, they sort of hold on to the patients till they fall into 80s and then they start coming into the hospitals. And that is actually when they're actually becoming on the critical side.
Sorry, Prof. Bilal, we can hear you very clearly, but your slides have a bit of a lag and it's very blurry. I'm not sure whether you can share a PowerPoint. Is this a PowerPoint sharing?
This is a PowerPoint sharing.
Yeah, but maybe you can continue. We just can't see your slide very well, that's all. But we can hear you very well.
Stop sharing and reshare the slide again. Yeah, now it's better.
Yeah, I think Bilal, it is better, but I think you need to share it again.
I'll do that.
Thank you very much.
Stop share. Here again.
So Bilal, as you're sharing, sorry, I got another prior engagement. I have to leave, and thanks again for APSC Cloud as well as PCS to organize this session. Professor Lin from Taiwan will take over the moderation and chair subsequently. Thanks, Bilal. Please carry on.
Thank you, and it was nice having you around.
Bilal, it is good now.
Perfect, sir.
Yeah, that's right now.
So we have got this going on, and you have this bit of critical illnesses patients going in. And from the one, you had all of these patients coming in that, when you're in the 80s, your probability of being lost is nearly 15%. And all of this information came in from there at that moment. So if you get exposed, in about 2 to 14 days, you start developing symptoms. And these symptoms may be anything from headaches, loss of taste, etc. And this is where the whole thing sort of goes right into the nausea and vomiting and diarrhea are there. If you are young, the probability is that you may just have ear, nose, throat complaints. If you're elderly, you may have a bit more, like loss of appetite, diarrhea. I hear friends from Rawalpindi, and we recall one of our earlier friends we lost probably to diarrhea over here. And then later on, as the disease advances, if you are get infected and you're young, you probably will be fighting it out. And but if you really get into a bad place, you nearly about 20 days for the final days. And while if the older patients, they fall in about 11 to 12 days. There's a whole list of what things may be happening. So I'll just go through the pulmonary involvement. The presenting complaints, of course, are the dry cough, the fever, sputum, productive, and may be productive, may not be productive. Initially, it is non-productive, and gradually it becomes productive, up to the fact that you start spitting out blood. Fatigue and dyspnea is there. Severity is that nearly about 80% of the patients remain asymptomatic. They never get to know about it. May have some little bit of cough, something mild pneumonia. And 14% will have severe hypoxia, and of them, about 5% another will go into critical and will progress into shock and respiratory failure and multi-organ failures. And out of these 5%, we'll lose about 2.5, 2.3, nearly half of them. And rest, we have yet to see how they are going to progress on. If you happen to get hospitalized, there is unfortunately a good chance that nearly 20 to 40% of them are going to develop ARDS. And these are basically the figures which are from the critical sites. Now, the SARS-CoV, the first one, the virus, and this the 19 one today, the SARS-CoV-2, they are very similar, and they have the liking for the ACE inhibitors, which have been discussed so many times, so many meetings, I'm sure by now. And it is basically spread out in your alveolar areas in type 2, and thus a big reservoir is available for viral binding and replication to take place. Leads to all sorts of bad things, alveolar macrophage phagocytosis and virus-infected hepatocytes and T-cell responses. And this all leads to a whole set of problems, which later on, of course, cause the cytokine storm also. But over here, before that, it's a diffuse alveolar damage and macrophage infiltrates, and hyaline membranes are formed. And all of this leads to basically a patient having into this thick, brownish lungs are then formed. At early stages of process, there is no DIC, but then everyone sort of, unfortunately, does go into an ARDS over here. Extensive microthrombi formation with vascular beds causes pulmonary infarctions, hemorrhage, pulmonary hypertensions, and secondary ventricular stresses. Hypoxemia and mechanical ventilations are required. And as you can see in the images, that you have all of these things going on. Chest X-ray is something that we are doing most of the time. They have got ground glass opacities, bilateral. It's not exactly very specific, but it helps you to establish it. CT, of course, is far more sensitive, but there's no 100% exact science over there which says that this is basically a COVID look of a CT finding. Now, the radiological abnormalities increase as the disease progresses, and that is something that is seen. But the most interesting fact is that many a times that you may have radiological findings and yet you don't have symptoms. In fact, you may have pure radiological findings and yet your PCR is still negative. So these are all across the board of various types of the things happening. CT, of course, is the best sort of screening tool because it can even pick up things very early. But in our part of the world, it is not really a recommended tool for multiple reasons. One, it is the expense behind. Number two, we don't have enough of them. And number three, you need to have dedicated CT scans for these patients then. And in between, otherwise, you really take a lot of time and expense to sterilize the whole area. So, and the hypoxia, it actually, the correction of that lags behind. Hypoxia is frequently the presenting feature, and at times these patients even present, they're hypoxic as far as the pulse oximetry may be saying, but they are feeling as such comfortable. And these are the ones which are silent hypoxic. and linked to the eight typical features of the ARDS. Now, this is something that is interesting for, at least for me, that there are basically two types of lungs. There's one lung which is the H phenotype, another which is L phenotype. The H phenotype has the elastase and high lung elastase and weight, and while the L is the low one, and the H is the one which has the pneumonia-like thickening and the lungs and requires ventilation to survive, while the L is actually the opposite side. It's something like, virtually like a stroke, which may be a hemorrhagic and which may be thrombotic. And the treatments are of the stroke, but totally wide apart. To date, the only way to confirm over here is also with the CT, as for a stroke it is. Another factor that may predispose for severe potential fatal ARDS is patients with COVID, is the excessive increase in the circulating pro-inflammatory cytokines, including interleukins and interferons and all of these things. And then there's this whole set of various treatments that I'm sure will be being discussed later on. So, but rather than going into this whole thing, I thought I'll show a case to you of a patient. This is a 60-year-old lady. She's obese, she's a diabetic, hypertensive, ischemic heart disease. She has got kidney disease. Her CRET is around 2.5. She has heart failure and has ejection fraction of about 25-30%. She's a complete sedentary lifestyle. She's in her BMI is around 35 or 37. She is dyspneic and comes in with dyspnea and cough and chest discomfort. So I'll share the slides and some X-rays and narrate you along what is happening. So she comes in with this X-ray and has a COVID test positive. I request her that you need to be in a COVID center to be looked after. So she goes over there and they start managing her out. Start off with the steroids. At that time, I think remdesivir was not yet in the market, and a lot of other drugs were still being discussed. So they started her with steroids. They started her with low molecular heparin and a blanket of antibiotics, including azithromycin, etc. This on the 15th, the pulse ox had actually gone down to about 85, and her oxygen requirements had shot up to about 15 liters. And her lungs, as you can see, the left side is now becoming quite white. Later, by the 18th, basic exercise, since she was a heavy lady, she could not really be placed in a prone position either. So she was just being basically done all the physical maneuvers, etc. And the center where she was, they did not have a ventilator at that moment available for her. So they never placed her on a ventilator and was being managed very much medically. And this is the time around the 22nd when they put her on ambulatory home oxygen and sent her home. And as you can see, the things have sort of improved, but not exactly what you may want her. And this gentleman is the X-ray just done on the 20th of November, earlier, a few days back. And as you can see, everything looks quite clear. And she as such is doing well, but because of her obesity, etc., there's a question of a DVT actually coming in. So we are looking into that now. This you all know about the aerosol services and the COVID SARS-1 and the 2, they all have their sticky natures, but the basic thing is that stay away from these things, and if you really want to use any of this stuff, take your precautions. Always get your things in a good intensity sunlight. As you can see that if you stay in the high intensity for just about a minute, 26% of it is lost, while in the cultural medium, 16% is lost. So 10-15 minutes can do great wonders for you. There were these studies of how the disease was being spread out. And of course, the maximum spread was taking place because of the indoors. 18.7% was a higher, and of the super spreaders, that is infecting more than 3 people, 6 out of 7 were in the indoor area. And these were all then later on also verified by various other cluster evaluations in France, in Germany, in the US, etc., and South Korea. If you all recall, this is the slides from the very first initial cluster evaluations of the families who were in Wuhan, and how they infected a lot of people over there. And this basically once again shows that if you're in a close proximity for prolonged periods, that is where you get into the problem. None of the waiters or the 68 other people in 15 other tables got infected. Basically, one who were all in the close proximity were the ones who were getting infected. So crowded places, and the longer you stay with each other exposed, and thus you must maintain aerosol dynamic distance of at least 1 meter away from each other. And a continued observational study and sentimental, and these have to be keep on going. So as the distance goes up from 1 meter to the first meter really makes a big difference, and then the second also adds into it, and if possible, do the third meter. So if you're in outspace areas, the more distance that you can easily come up with. If you're sitting in your offices, make sure that you're maintaining at least 1 meter plus distance from each other. And if you're working in an environment which is full of such problems, then you can have actually a shield in between also. Over here, as you can see that having the surgical masks and N95 made a bigger difference. And those who were not wearing these masks, 3 out of 10 had the respiratory droplets, and 4 out of 10 had the aerosols, while those who were wearing masks, none of them got it. Thus, in short, as far as this is concerned, physical distancing is important, hand washing is important. If you're a health worker, you must wear your the personal protection equipments. And if you're looking after elderly, make sure that they are doing the basic care. And if you are traveling or in confined spaces like railway cars or such places, then you must wear your mask, etc., and do all the necessary, all the more. This is just an X-ray of how the things start to appear. Study done from here, but I think you'll rather be interested in this one. This is a dynamic CT scan, and I'll just quickly shift to where you start seeing the lungs. And over here, as you can see the lungs coming up, you can see these white fluffy shadows all coming up, the ones that we are all the time talking about, that these are the things that our pulmonology friends are all the time warning us that if they start developing, then the patients start getting into a problem. This is in a dedicated COVID lab where this investigation was carried out, by the way. So don't be afraid about that. So, so all these CT scans make a difference. They help you to get to your diagnosis quickly and with certain amount of confidence, and then you can stick on and work accordingly. Extra pulmonary manifestations, since I had to do that also a little bit, so I just ran through. We have done the cardiac part, and I'll just run through the others a little bit. The GI part, well, the virus has an affinity for ileum and the colon. The COVID-2 unfortunately has more than the COVID-1, and excuse me for the cough, probably going fast, that's why I'm having it. And 16% of the patients had only GI symptoms. The most common symptom reported was loss of appetite, vomiting, nausea was always there, and diarrhea 37%, abdominal pain 25%. Cross-section study from Hubei province was also done. 99 patients they looked at, and 48.5 had GI symptoms. Anorexia was the main thing, and then diarrhea, vomiting, abdominal pains, all of this was there. And 7 patients of them only had GI symptoms and did not have any respiratory symptoms. So the patient having just GI symptoms may actually be, in current day and time, be looked into the COVID part also. And further data is going on, and this you will find most interesting, that patients may have negative pharyngeal yet for the sputum, but their fecal samples may be positive. So this is something that also needs to be looked in case the history is strongly suggestive. That is something that to be looked at carefully. And the virus tends to survive longer in the stools also. So liver, yes, it takes the bilirubin up, it takes AST, ALT both up. As such, no major liver problems have been reported, but liver dysfunction is mainly described in patients with severe disease upon presentation. And that can be because of so many other things like the sepsis and the hypoxia that the patients have. One patient, they had the microvascular holes analysis done. And because these hepatocytes and the cholangiocytes have the ACE inhibitors, thus the whole hypothesis exists that it may affect the places. Studies demonstrate that GI symptoms and hepatic toxicity are not uncommon among patients with COVID-19 disease. Hematological, of course, is something that is being seen all the time. Lymphopenia is the cardinal feature over there. Takes 7 to 10 days, and then you have this whole cytokine storm being built up. Neutrophil lymphocyte ratios and the peak platelet and lymphocyte ratios have determined the severity of the disease. And lymphocyte expresses the ACE2 receptor. On these surfaces, the SARS-CoV virus may directly infect and thus cause the cytokine surge, may promote lymphocyte apoptosis. Another thing, unfortunately, is that substantial cytokine activation may be also associated with atrophy of the lymphoid organ, including the spleen, and further impairs lymphocyte turnover. Abnormalities in hematological parameters have been more prominent amongst severe cases. Yes, this is expected, and that is the way it works. A meta-analysis of 9 studies all show the same thing, a very high between heterogeneous, and though sizable drops in platelet counts was noted, especially in non-survivors, unfortunately. And longitudinal evaluation of lymphocyte count, dynamic and inflammatory indices included LDH, CR, PIL, may help to identify cases with dismal prognosis. So thereby actually not curtailing you, but making sure that you are staying away from the bad side. These are, of course, all the markers which have come on the CRP, the ferritin, which are poor prognostic markers, especially when they're rising. More recently, high cortisol levels at presentation may reflect disease severity and have been recognized as an adverse prognostic factor. Furthermore, blood hypercoagulability is common among hospitalized patients. Elevated D-dimer levels are consistently reported, whereas their gradual increase during disease course is associated with clinical deterioration. Prolongation, other coagulation like PT and APDT, increasing fibrin degradations, all of these things are there. Endothelial dysfunction and immune deregulations may be implicated in the underlying pathophysiology. COVID-19 infected patients are at high risk of venous thromboembolism, also of arterial, by the way, and up to 10% of them have it. Comorbidities along with possibly the endothelial cell activation and damage due to virus ACE greatly increases the risk of the venous thromboembolism and prompt pharmacological, etc. In neurological side, third of the patients have neurological features. Of them, nearly 25% are CNS, 9% are PIR of the peripheral nervous system, and about 11 are for the skeletal muscles. More in severe cases, these is the whole hierarchy of the dizziness, headaches, decreased consciousness level, taste, etc. So they have all of these things which are coming up. And the sad part is that some of the reported symptoms such as inattention, disorientation, movement disorders persist even after discharge. SARS, MERS, and now COVID-2 all can infect the brain either through the hematological pain or may go through the direct pathways. ACE receptors are found in the nervous system and the skeletal systems, and may actually even worsen it, worse things like mimicking like herpes simplex. Excessive immune response, which reflects the hyperinflammatory status, and cytokine storm may represent another alternative mechanism than cytokines, etc. And they actually have also been shown as things like with the Guillain-Barré syndrome kind of thing, and transverse mellitus cases have been attributed to it so far. Neurological symptoms caused by systemic illnesses, especially in severely ill patients, could also justify neurological manifestations of COVID-19 infections. Patients in ICU usually end up with encephalopathy or myopathy or such kind of things. 5.5% of both hemorrhagic and ischemic strokes was seen. SARS-CoV infection is hypercoagulable state and may predispose to both venous and arterial thromboembolism events. Imbalance between procoagulant and anticoagulant hemostatic mechanisms may result in endothelial damage. These days, I've just had a patient. I'm looking after her upper limb ischemia. I don't have any feature why it should be, because all her other markers are good, but she lost her pulses all below the brachial artery. Some of them have recovered. Yes, we are intervening into it, and hopefully something good will happen out of it. And blood pressure alterations and hypotension and hypertensions are all later on cause problems to cerebrovascular features over here. Your loss of smell, the loss of taste are all over there. More common in ladies. Recovery is 44%, but it usually takes longer than the 14 days of recovery. And still a lot more needs to be learned. The kidney involvement is there. ACE is present everywhere in the kidney. And the most frequent abnormality in patients with COVID is mild to moderate proteinuria, which is mediated by several mechanisms. Of course, all of these things is there. And cytokine storm, when it hits, it causes sepsis-associated acute kidney injury. In addition, alterations in renal hemodynamics may further induce dysfunction. AKI, acute kidney injuries in just the mild patients is about 5%, while as the disease progresses, you start having proteinuria, nearly half of them and 1/4 of them having hematuria. 13% reveal elevated levels of serum creatinine and blood urea nitrogens of both. And all of this tissue microdissection was done in about 6 patients' kidneys. And over there, they saw near a third of the kidneys, half of them, in 3 of those kidneys, half of them having SARS in all areas of the kidney. So kidney abnormalities are common and are associated with worse clinical outcomes. So if your patient starts raising his creats or his proteinuria starts coming, please be very careful now. Skin manifestations is another thing. Skin abnormalities are seen in up to 20% of the COVID patients. Very heterogeneous, ranging from urticarial, vesicular purpuric, etc. Not clear whether these skin manifestations are caused directly by the virus invasion or secondary to host immune response itself. Purpuric eruptions, livedo reticularis, etc. are all over there. And the nature of association between COVID-19, etc. still have a lot to be done by the dermatologists. But just for your bit of taste, I had these patients' photographs taken. And look at all these skins. These are young person's skin and looks like an old man's skin over here. And on the other hand, just look how easily it is aberrated and how thin the skin looks. So something needs to be looked into it, and we need to do some tissue biopsies over here and some electron analysis also carried out. Endocrine abnormalities, knocking down the cortisol stress is the strategy for the COVID virus, and they mimic the ACTH, etc., and cause all the problems. Data on serum cortisol levels are scarce, but at the moment, and things they are working on it, and they are getting up their studies into it. Autopsy studies from SARS-CoV virus infected have demonstrated degeneration and necrosis of the adrenal gland, and the virus has been identified in the glands themselves, pointing to the likelihood that cortisol dynamics are altered in the SARS-CoV virus infection. And the hypothalamic pituitary adrenals axis might be affected. And I found this trial marks that is going on. A prospective study is being evaluated to see how things are going on over there. Eyes, ophthalmic side. That everyone thought that eyes are the doors to a man's brain, etc. But in animals, they have seen that ocular manifestations are there. Initially, it was thought that humans don't have it, but they did a study on 12 patients with optical coherence tomography, and they found in 4 of them having wolf spots and micro hemorrhages. This did not affect their visual acuity or pupillary reflexes, but nonetheless, this is there and needs to be looked into it carefully. So a lot of these things are going to go on and coming around again, and we all need to see how things will take us. Regarding to this pregnancy question, which was also put up, luckily I have a few slides, so I just quickly added them into it. So these women are at a higher risk, those who have the COVID thing, and there are more chances of them ending up in a ICU if they're the pregnancy. You can see from the data over here that pregnant 54% and the non-pregnants are at 38%, and the symptoms are as such are all virtually the same which go on, and they had a good across-the-board analysis as such carried out. Similarly, over here, we had the ICU admissions for the pregnant was about at 1.5, or the non-pregnant was 0.9, and there was a skewed analysis also was done. So pregnant patients are at a higher risk, no doubt, than the non-expectant ladies. Pregnant with severe COVID-19 appears to have increased risk of preterm and cesarean deliveries. This was all noted earlier. Rupture of the membranes was noted. And over here, as you can see that they had these 420 patients, and 20% delivered before 37 weeks, and 85% were delivered by a cesarean section. Similarly, another one, it said 61% were asymptomatic and 31% subsequently were asymptomatic, and 14.6 preterm births. So yes, these patients are at a higher risk, and more cesarean sections are being done over here. Regarding the prospective cohort, 245 babies, 30% of the newborn resuscitation beyond the standard times, 25.7 admitted in children ICU, and 62.4% were hospitalized for more than 2 days. Big numbers which are there. And the rates of spontaneous abortions was roughly the same. As far as in utero congenital, it's still too early to talk about these things. It was noticed that the high viral load people on day 3, the neonates had sudden irritable, poor feeding, axial hypertonia, and were brought in over there. They were managed, symptoms improved slowly over 3 days, and MRI was said in about 18-20 days they were then discharged. So these children were also at a higher risk of the mothers with documented viremia delivered in the third trimester. These are a whole set of medications. I'm sure we'll be listening to it later on. And basically, the basic thing is that infants' rooms with mothers need to may opt to keep their children away, and they may pump their milk and give it to the caregivers to be fed. And so this is basically a lot of individuals' decisions and a society's way of managing the whole thing. Regarding just the children, I'll just give you one slide quickly. That yes, the children as such are less affected, both in terms of hospitalizations and death, but they are. So if you have a 0.1% risk going on, so you are losing one child in 1,000. And as the numbers keep on growing, especially for countries like ours, where a high percentage of population is under 20, so we really need to be very careful and warn these children that you are at risk. So with that, I will just simply say thank you for your time and keep safe, and organizers, and wash your hands, wear your mask, and keep your distance. Thank you.
Thank you for Dr. Vilas into his talk. Any questions from the panels? Dr. Rimna, you have a question about? Just now, Dr. Rimna is asking, is the mortality of other clinical disease as severe as cardiovascular disease during COVID-19? Dr. Vidal, how do you feel about it?
Sorry, I didn't get it. Can you repeat the question?
Yes, they are asking if other clinical disorders, they also have a similar mortality as like in cardiovascular diseases.
The disease is actually quite severe, and the symptomatology is immense. At the moment, our guidelines as far as cardiac, etc., is concerned is that a patients who are coming in, the center where I am working is a dedicated COVID center. So for us, it is taking on patients only who have got coming in with some acute emergencies. And you do not have an exposure history behind. If there is an exposure history behind, they are managed on conservative lines. If there's no exposure history at the backside, there's no fever, etc., then we do bring them into the cath lab and go for this. But the reality is that these are all tender caring taking patients, and they put the health providers also at risk. So what we try and do is that try and find a balance in between, and do the needful and yet not be exposed. So the senior faculty members are kept slightly at the backside. The juniors, which we feel are the ones which are more healthy and will be able to, God forbid, if they end up contracting the disease, they will be more able to fight better. Our experience at the moment over here is that we have lost a couple of our senior doctors who went out as the first soldiers, and while some of our young boys and girls who went out as first soldiers, they did contract the disease, but were isolated, and most of them have recovered. We had a few initial casualties, but that was basically because of the wrong and early, not quick enough diagnosis being established, not quick enough treatments, and one or two of them actually had multiple other comorbidities, immunosuppression. And so if you are an immunosuppressed person, you are not supposed to be in a COVID unit looking after patients.
Okay. Is there any question?
Can I ask a question?
Yes.
Can I ask a question from Bilal?
Assalamu alaikum, Shahbaz Sahab. Good morning, sir. How are you?
I'm fine, thank you. Bilal, thank you very much for a very exhaustive and informative presentation. Have you or anyone else in the who have presented here and who are the panelists seen any patient who has come to us with an acute viral pancreatitis as a manifestation of COVID-19? Because I have seen one patient and was very serious, but ultimately did come out of it. And there's one case which is reported in literature as well of an acute pancreatitis as a first manifestation of COVID-19. What is the experience of others in the panel and of Bilal?
So luckily for me, as far as direct handling of abdominal pain is concerned, it is outside my domain as such. But if you notice that 25% of the patients have abdominal pain, especially if they're having GI symptoms. Now, these GI symptoms may be coming from any part, and as also pointed out, the biliary canaliculi, etc., they are lined by cells which have got ACE receptors over there. So one can always come up with the hypothesis that yes, they had acute pancreatitis, they had those inflammations over there, but whether someone had the energy and the abilities to at that moment go and put a scope over there, get a direct sampling done from there, and only then could the exact diagnosis secondary to COVID could be established. Which these are all findings which are suggestive of it, but the patient's stools, etc., they may all be there. But having said all this, so I'm sure there are people who are far more experienced in the panel sitting over here who may be coming up with some better opinion.
Actually, this patient had a very high amylase and lipase and was seen first by a surgeon, but then when the COVID test was done, it was positive. And I thought, then I looked up in the literature and I found that there was a case of an acute pancreatitis secondary to as the first manifestation of COVID. And you have rightly said that since they have the ACE2 receptors, their chances of them having pancreatitis is very much there. So instead of putting in a scope, I think a blood sample of amylase and lipase would be very useful in these patients.
Perfectly right. I remember one of my patients, he came in with angina, and his coronary angiogram had been done up, and he wanted an angioplasty to be done. It was a rather tricky one. And part of my routine evaluations for elective cases is that I request them for a COVID analysis. This gentleman, mind you, was completely asymptomatic as far as any COVID business was concerned. But hold and behold, the COVID was positive, and thus the case had to be postponed. So you keep having these anecdotal examples coming here and there. But the hard fact is that the COVID business is tricky, and especially when it comes down to handling these patients.
Because
Dr. Shehab, Dr. Haroon, Babar here.
Yes, because of time shortage, I have to move on to the last speaker. The last speaker will be Dr. Shehab Lakshmi, and Dr. Lakshmi is the topic she's going to talk about is the review of the latest effective therapy for COVID-19 and vaccine update in December 2020. Dr. Lakshmi is currently an assistant professor of infectious disease in Seheult University Health Science, and also the consultant infectious disease Karachi Adventist Hospital. Dr. Lakshmi, please.
Yeah. So I think we had excellent talks on presentation and severity, manifestations, epidemiology, and different manifestations of COVID. So I'll stick to my talk on management of COVID and what are the recent updates, what is the current evidence. Can you hear me?
Can you share screen?
Yeah.
Share screen presentation.
Just hold on.
कहाँ पे?
अमरूद है।
कोविड में? तो आपको प्रॉब्लम एक तो है ना, आपने एन्यूरिज्म का ऑपरेट करा है, और क्या है? हाइपरटेंसिव है? नहीं वो तो आपने बताया नहीं फिर
So, hi.
Okay.
Hi, everyone.
Yeah, we can see the screen now.
This is
Haroon, you
Dr.
need to switch
Shobha.
on the mic.
So, it had been an excellent presentation and webinar since morning. And we have been listening about the epidemiology.
क्या दवाई क्या लेते हैं
Hello? The voice is echoing. Hello? Can you hear me?
Please continue. Please continue.
Yeah.
The voice is good.
So there had been, so my focus would be on the management and the current evidence regarding vaccines and where we are. So manifestation. So WHO has classified COVID according to severity, that is non-severe, absence of signs of severe critical disease. Severe, the patient is desaturating, and on room air, the oxygen saturation is less than 90. Respiratory rate is greater than 30 in adults, and signs of severe respiratory distress. And critical is acute respiratory distress syndrome, sepsis, multi-organ shock, multi-organ failure. And according to these classification, we manage patients and we admit them in hospital, and then there is a role of different drugs. So before we go further, it is really important to understand the pathogenesis and immune response to SARS-CoV. So if the immune response is adequate, that is type 1 interferon response.
Sorry, Dr. Shobha, your slides are not changing.
They're not changing. Okay.
And you have to put on the slideshow first. You put on the slideshow. You are not on the slideshow.
Okay, just are they now? Are they changing now?
No, you are. Actually, we are seeing you. What you can do is slide share again, and like Professor Bilal said, you go on to the slide presentation.
Okay, just give me some time. Slide share.
Touch the last button on the slides. Change slides on in the right lower side. Yeah, that's right now.
You got it.
Yeah. Now it's okay.
Perfect.
Shobha, you're on.
Okay. So just let me do it. Sorry for these technical glitches. Okay, so I've told you about the classification. So we manage patients, COVID patients according to the severity. So those who are non-severe are managed at home and they do not require any specific treatment. The ones who are severe with desaturating on room air and oxygen saturation less than 90 are admitted, and the ones who are critical are admitted in SCU and HDU. So it's before we go on to treatment and vaccine, it's very important that we understand the immune response to SARS-CoV-2, and this is where we intervene. So if the immune response is adequate, that is timely, innate, and adaptive response, and type 1 interferon response, and activation of Th1 and B cells that resolve the normal immune response, the majority of the patients recover. It's when the cytokines are activated and there is delayed or limited type 1 interferon response, epithelial and endothelial damage, and there is a cytokine storm. This is which when the patient presents with severity, and this is associated with comorbidities. So someone having obesity, older age, diabetes, mellitus, The immune response is dysregulated, the cytokines are activated, and the patients end up in the hospital with severe disease, and this leads to lung injury, septic shock, organ failure, coagulopathy, and ultimately death. So this is very important that we intervene here, that the patient progress before the patient progress into to the cytokine storm, and there is this activation of the cytokine cascade. And the trials and the evidence show that the earlier you intervene, the earlier you start antiviral and anti-inflammatory and immunosuppressants and immunomodulatory drugs, the patient are less likely to progress to the severe disease. So this is the clinical suspicion and criteria for testing. So anyone who is presenting to nowadays with fever or cough or shortness of breath, any one of these, or severe acute respiratory illness without any clear cause should be tested for COVID. Or someone who had a confirmed contact with a confirmed or suspected patient of SARS-CoV-2. And close contacts include healthcare associated exposure, visiting patients or staying in the same close environment, sharing the same clean washroom environment or same office space, traveling together in similar transportation, or living in the same house. So technically, anyone who presents to your clinic with your fever or cough or shortness of breath or severe acute respiratory distress without any clear cause, I think in these days should be tested for COVID, right? So someone who has contacted the disease and suggestive of esophageal swab should be sent for antigen testing or for COVID PCR. There's no role of antibody testing in management of COVID. And IgM just tells you about the acute infection. IgG tells you nothing. So it's still the gold standard is PCR, but now the rapid antigen tests are available, which gives you results within half an hour, and you can decide that whether to be a patient in COVID area or treat him as COVID, or send them look for an alternative causes. But it's very important that keep a index of suspicion with high, because even these tests have sensitivity of 70%. Then the main important thing, which is often overlooked in the management of COVID, is infection prevention and control. So the first most important is early recognition, early triage, and early infection control measures to prevent nosocomial outbreaks and transmission into the community. This is the most important element of controlling space. So majority of the cases, our healthcare workers, they may have acquired it in the community, but still it's our responsibility to prioritize on infection prevention and control. So early recognition, identify points of entry where patients are likely to arrive, and encourage healthcare workers to have a high index of suspicion, have a respiratory triage at ER and clinic, and all healthcare workers should wear PPE. It's mandatory now for healthcare workers to wear masks all the time, to wear gowns, to sanitize their hands often, and it's important that whoever walks into the healthcare service should wear a mask. It is very important. So the areas where resources are limiting, you can just have this simple triage. So someone who is having cold, flu symptoms like sore throat, hello, can just walk into a separate area where they are evaluated, antigen tests can be sent, and they are then managed accordingly. Someone having all the symptoms, no cold, flu-like symptoms, can walk into another area and where they are evaluated accordingly. So WHO now recommends that all suspected cases should be separated from the patients, from the routine patients. It is very important that the standard precautions are practiced all the times in this tough times. That is, practice hand and respiratory hygiene, medical masks to patients, all the patients who are walking into your clinic. If they are tolerate, just offer them one. If they are very short of breath, just give them supplementary oxygen, and you yourself wear mask. If you are doing some aerosol generating procedure, wear N95 mask, prevent needle, stick, and sharp injuries, and practice safe waste management, environment cleaning, and sterilization of patient care equipment and linen. So this is the way I mean, this is standard, had been there for years, and there is a sequence for wearing PPE, that is gown, mask, respirator, goggles, and face shield and gloves. And there's way of taking off PPE, because majority of the people get infected when they are doffing the PPE, not when they are actually downing. So asymptomatic patients do not need admission. They do not need any specific therapy, and they can be safely home isolated. There is no role of of antibiotics in management COVID. So this, I mean, in our part of the world, azithromycin has been widely used in the management of COVID, but azithromycin is an antibacterial agent. There have been evidence that it does not help in the management of infection. It's a viral illness. You need immunosuppressants, you need antiviral, immunomodulatory therapy, supportive care. And for the non-severe disease, no specific treatment is required except supportive management, that is paracetamol, anti-allergic, cough suppressants. That's it. Nothing specifically is required, and the disease resolves on its own. It's like any other virus. The patients who are immunosuppressants or have severe comorbid conditions like heart failure, decompensated liver disease, such structural lung disease, uncontrolled diabetes, and chronic kidney disease warrant admission. So someone who has severe disease needs to be admitted, and either if he's not, he can be managed with only supplementary oxygen in a well ventilated general, or someone who needs assisted ventilation like non-invasive ventilation, BiPAP, CPAP, multi-organ failure, or someone having needed ventilation should be admitted to a high dependency units or ICU with negative pressure rooms. If there is no negative pressure rooms available in surgery, make sure the room is properly ventilated and all the staff wear PPE all the time. So mild COVID is really can be managed at home and designated, or if there is no isolation available at home, in a designated COVID-19 health or community facility. Treat symptoms only, no antibiotics. I emphasize this on this again and again. There's no role of azithromycin or antibiotics in the management of COVID. It's a viral illness. It's absolute. And I'm scared that one day we will lose azithromycin as a very effective drug for the management of typhoid and other disorders which are prevalent in our part of the world. So just adequate nutrition, appropriate rehydration, antibiotics for fever, educate patients on signs and symptoms of complications develop, should seek urgent care, and you should tell them, because the COVID patients, if they are with comorbidities, they deteriorate very rapidly. So just ask the patients, just counsel them that if VLF desaturate and the oxygen saturation goes below 92 on room air, they should seek medical care. We can use, in Pakistan, we are using services of telemedicine for managing COVID patients at home, and this can be offered to the patients. They can get telemedicine when the hospitals are overwhelmed. And close monitoring is advised for symptomatic patients with risk factors. No specific labs, nothing is required. This is a mild disease, this will resolve on its own. And 70 to 80% patients fall into this criteria. So it's better to stay home if someone is having mild symptoms. They even don't need to come to the hospital, because this actually increases the risk of the transmission. And no needs of anticoagulants and antitelatory therapy to prevent arterial or venous thromboembolism unless other indications are there. So they've been abuse of anticoagulants and antiplatelet therapy in patients who are having mild disease. The evidence shows that does not show any benefits. Only in patients who are severely ill and admitted in hospitals, they actually need anticoagulants and antiplatelet therapy. Otherwise, it's not required. Moderate, you can either manage them at home, or they can be admitted in a hospital, monitored closely, as pulmonary disease can rapid progressively. If there is a suspicion of bacterial pneumonia or sepsis, Then you can give empirical antibiotics and blood cultures, say procalcitonin. And procalcitonin is low stop antibiotics. Procalcitonin can be used as a marker for bacterial sepsis and can be used as a guide to start or to stop antibiotics. Because again, my say is that this is a viral, and that's what other people, researchers think, that's a viral disease, and there's no role of antibiotics in this matter. Ensure that infection prevention and control measures are in place. Limit numbers of care providers. Staff should wear N95 mask or PR. Infection control is very prudent in its management. Again, no specific treatment, but this is the phase when patients are in mild COVID. We can give them oral steroids and remdesivir, and I'll show the evidence that when the steroids are given at this stage, they progress to there is evidence that they actually do not progress to the severe disease. So steroids, oral steroids, in a dose of 20 milligram twice a day, can be given to these patients, prednisolone, and there is evidence that they do not progress to the severe disease. So there is no evidence of using antiviral at this stage in moderate disease. No role, or absolutely no role. It's just I mean, steroids are the treatment in moderate COVID. So if patient is hospitalized, gets CT, chest X-ray, HRCT if available, ECG, CBC with differential, and it's really watch for lymphopenia, because that is one of the markers and one of the prognostic scores. So if it's really going down, the patient may be the patient is at risk of progressing to the severe disease. Get CRP, D-dimers, ferritin, because they are prognostically available markers. Severe COVID actually needs, I mean, this is the category which really needs aggressive management, and this is when really intervention is required. You have to be vigilant, because they may progress rapidly into critically illness, and this is where the role of antiviral and IV steroids is there. So admit them in HDU or in ICU with pulse oximeters, functioning oxygen systems, single oxygen delivering interfaces, immediate supplementary oxygen if the oxygen saturation is less than 90. Monitor for clinical deterioration, that is rapidly progressive respiratory failure. Practice cautious through management, because these patients are also at risk of developing pulmonary edema and ARDS. If there is acute co-infection you're suspecting, start antibiotics empirically broad spectrum, send blood cultures, rain procalcitonin, and review in 48 hours. And these. So this is actually a very good slide, and the slide is taken from clinicaloptions.com. So this is when, I mean, actually the therapy provide benefits. So this is when the clinical symptoms is viral response stage 1, early infection, and mild constitutional symptoms and lymphopenia is there. This is when actually you can use oral steroids, and this may help. I mean, this is an only viral response. Then in stage 2, when the pulmonary disease is there and when there are chest infiltrates, this is when the viremia is there. And there is shortness of breath, there's abdominal chest findings, there's transaminitis, low normal procalcitonin. So remdesivir has a role. Remdesivir can be given in this, and there's no role, no benefit is seen of remdesivir. The evidence show that remdesivir was given after 10 days of infection. There was no benefit, because this is when the viremia resolves and actually hyperinflammatory phase develops. Just give. Hello, sorry for interruption. So yes, so this is when when actually remdesivir has roles, and it has no role after 10 days, I told you. And then when the hyperinflammation phase, the inflammatory phase sets in there, when the patient has ARDS, cytokine storm shock, cardiac failure, elevated IL-6, D-dimers, ferritin, CRP, then there is role of IV dexamethasone. So this is a very beautiful slide which says COVID therapeutic strategy at different stages. So IDSA, that is American Infectious Disease Society of America, recommends dexamethasone only in severe COVID, and remdesivir also in hospital patients with severe COVID. The lopinavir, ritonavir, or convalescing plasma should be used only in clinical trial settings, and it recommends strongly against hydroxychloroquine and hydroxychloroquine and azithromycin combination because severe arrhythmias and fight. So in non-severe COVID, there is no role of glucocorticoids. Tocilizumab, which had been widely used in management of COVID, but there was no, the evidence shows that it did not really benefit, and the outcomes were not really improved with tocilizumab in mechanical ventilated patients. In fact, it increased the risk of sepsis and bacterial pneumonia and fungal infection. So really, use this drug with caution, right? So, I mean, still the cornerstone is systemic corticosteroids. So like someone who presents with ARDS, sepsis, septic shock, steroids is considered the cornerstone of treatment, systemic corticosteroid. So anyone who has oxygen saturation below 90, respiratory rate greater than 30 breaths per minute, signs of respiratory distress, use systemic corticosteroids, and I mean start them early rather than late, because this may prevent progression to the severe disease. In a recovery trial, it was seen that heavy dexamethasone has significant benefit on the motility, and that's why the trial was stopped before. So this is the concentration. So standard is in a severe COVID is dexamethasone 6 milligram oral or artemis. Alternatively, 50 milligram hydrocortisone can be used every 8 hours for 7 to 10 days. Then methylprednisolone 10 milligram intravenously every 6 hours, or prednisolone 40 milligram orally daily. So this is an alternative. So if dexamethasone 6 milligram is equivalent to hydrocortisone 50 milligram, methylpred 10 milligram 6 hourly, hydrocortisone 50 milligram 8 hourly, and prednisolone 40 milligram daily. Patients with ARDS, oxygen and ventilatory support, and also when they are in the they are having endotracheal intubation, airborne precautions are required, and healthcare workers should wear N95 mask or respirator. Preferably, it should be done in negative pressure rooms. Monitor for deterioration. Prone ventilation has been shown beneficial 12 to 16 hours per day in adults with severe ARDS. Prone ventilation has shown benefit. And even on ventilators, we do prone ventilation, and and sometimes we do go for awake prone ventilation. We've seen good outcomes on it. In case of moderate to severe ARDS, higher versus low PEEP suggested individualized titration and monitoring, right? So this is on management of complications. So assess Delhi for readiness to wean. If there is a ventilator associated pneumonia, start antibiotics and implement ventricle bundle. Now this is the patient that actually needs therapeutic anticoagulation. That is when actually the D dimer is really high, greater than 500, and this is when there is a benefit of therapeutic. Someone who is at home doing fine, has a mild to moderate COVID, there's actually no role of giving therapeutic anticoagulation. So really, I mean, this has been misused a lot, but with these patients just need supportive treatment. You can give moderate cases steroids, but no therapeutic anticoagulation. WHO and IDSA recommends therapeutic anticoagulation only in patients who have severe COVID, who are hospitalized, who are in ICU, need assisted ventilation, and dehydrogenous. Otherwise, it's not required. Septic shock, yes, it's one of the inhibitors. You can use vasopressors and fluids accordingly. We really watch out for fluid overload because these patients are ARDFs and may get into fluid very easily. So really assess the need and give fluid under monitoring. Renal dysfunction is really common in these patients. In someone who has critical COVID and who is into so AKI, acute kidney injury is seen, so they may need renal replacement therapy. Again, say should not be used outside the usual standard of care, and only in severe cases you need venous thromboembolism prophylaxis. On patients who are hospitalized, they're therapeutic only, who has severe COVID and who are into the need assisted ventilation. Discontinuation, the CDC says if someone has greater than 24 hours since resolution of fever without antipyretics, improvement in symptoms, that is cough, shortness of breath, and greater than 10 days since symptom onset from mild to moderate illness, and greater than 20 days for severe to critical illness, or those severely immunocompromised. So now if someone is asymptomatic from the desktop test, if someone has been isolated for 10 days, they can de-isolate. If there is no fever for 24 hours, they can de-isolate. For mild to moderate, it is just 10 days for 20 days for critical illness. And now there is no test strategy. So you do not need to repeat PCR. No retesting is required. So these are different trial medications and they should be used only. Remdesivir you can use in moderate to mild disease, but if they have been moderate to severe disease and patient has signs of pneumonia on chest x-ray, but if the patient is mechanically ventilated and there had been more than 10 days, no role, absolutely no role of remdesivir. It does not improve survival. It only shortens the duration of stay in hospital and resolution of fever if given early. That is from 5 to 10 days of symptoms and patient is not on mechanical ventilation. So no evidence, and it has been shown. These are all immunomedical. Corticosteroids, dexamethasone has been shown very effective. Other anakinra, tocilizumab, intravenous immunoglobulins, JAK inhibitors, they should be used only in trial settings because there's no obvious benefit of using them. The trials show there's no benefit. Someone who is going home, someone who is and the family is someone who has so it is very important that the attendants should be counseled on the measures of infection control. They should perform frequent hand hygiene, should wear masks while giving care to the patients, and should practice hand hygiene, and they should monitor themselves for the symptoms of fever or cough or shortness. There also been seen long COVID syndrome, that is post-COVID, and we've seen seeing this along. That is after COVID, the PCR has been negative. The patients are presenting with low-grade fever, fatigue, difficulty in breathing, joint pain, and chest pain. And it's very difficult, and it's still there's no evidence how to manage them, but anti-inflammatory and steroids do give some response in these patients. They may respond to bezisterim, but this fatigue, the breathlessness, this low-grade fever may remain for a long time, which affects severity, the quality of life. And now it's very important that the research focus should be on the long COVID syndrome as it was in the post-Ebola syndrome. So sorry, I missed one slide. It's not there, but there have been ongoing trials and on vaccine and Moderna, Pfizer, which are messenger RNA vaccines. There's been ongoing trial on it, and it has been shown very effective. That is 94 to 95% efficacy, and probably these vaccines are will be available next year. Moderna and Pfizer vaccine are actually messenger RNA vaccine, which are a novel vaccine and haven't been used previously. Then there is a Janssen bio vaccine, which is actually a vaccine, which is a vector vaccine, and the trial in Pakistan is part of this trial. There have been successful results, and in phase 2 trials, this had been very good, encouraging. This is a Chinese vaccine that is Pakistan is part of. Then there is another vaccine, AstraZeneca, in association with Oxford University, is launching a vector viral vaccine in which the viral genes are inserted into a vector which which is a virus which is non-pathogenic. So there have been encouraging results with it. So I am and the world should keep their fingers crossed, and hopefully we will be having a vaccine in the next year and will be able to fight this pandemic. So I'm really forward to, and the world is actually looking forward to these vaccine trials, and there have been encouraging results with this Moderna and Pfizer vaccine, and hopefully they'll be launched next year. So I mean, this is a pandemic. This has been taken everyone. One in the world is actually in a fix what to do, not to do. But I think with determination, with good early diagnosis, uh, early intervention, and social, by maintaining social distancing, hand hygiene, and early treatment, I think we can control it. And let's hope these vaccine trials are successful and something positive come out of it. So that's it. Thank you so much for being a wonderful audience. If there are any questions, please do let me know.
Yes. Thank you for Dr. Yoga's talk. Because time limit, we only can have one short question. Yeah, any questions from the?
Yeah. Yes. I'm Dr. Shireen from Pakistan. I work in Sindh Government Hospital, Karachi, as well as in Karachi Adventist Hospital. I recently had an experience of COVID-19. I was PCR positive twice, but I was diagnosed on CT scan for COVID. And I was admitted in a hospital where they gave me steroids in the ER, and also antiviral as well. And my main question is, I was given tetracycline for 7 days. And I was also given ivermectin. I want to know what is the role of ivermectin in the treatment of COVID. Ivermectin, I read it, that it is antiparasitic, whereas I had no symptoms. Ivermectin, sorry.
So ivermectin the evidence does not support its use, and it should be used in only trial settings. The WHO, IDC, and all the organizations advise use against its use only in trial settings. It can be used. There's no role of ivermectin. I don't know why they give you doxycycline if you did not have bacterial pneumonia.
Yeah.
Because the time limit.
So I don't know it's a role. I mean, why did your prescriber? But ivermectin is essentially a drug which should be used in trial settings only.
Anyways, I thank God that I recovered quite fast, and within 14 days I was back to my duty. And but my still question is that why I was given that
I don't know. I can't commit. I'm just shared the evidence with you, and now you're a best judge. Right?
Okay.
So thank you so much for being a lovely audience, for giving me this chance to speak here. Actually, I have another meeting. I'm part of COVID task force in my hospital. So please accept my apologies. I have to go urgently. Thank you so much. If there are any queries, you can just leave.
I will have to close the section. I will transfer to Dr. Vimna to make any closing remarks for the whole section. Dr. Wimler, Dr. Wimler, yes.
Thank you. Good afternoon and good evening, depending on whatever time zones we are in. I would like to thank all who are present here and are attending this symposium on COVID-19 and its related health issues. Thank you all for making this symposium a success. We had an extremely useful day today. We have learned a great deal and are very much indebted to all of our speakers who have discussed and shared their knowledge and experience about COVID-19. I am grateful to them and appreciate them for accepting the invitation despite of the different time zones. I would like to especially thank Dr. Roger Seheult from California for sharing his presentation on epidemiology data and public health measures that are impactful, though it is quite late for him in the evening that side. I would like to thank Professor Abdulla Shehab from UAE for his sharing on the topic of cardiovascular complications of COVID-19 and its management. Thank you to Professor Bilal Mohiuddin from Lahore for taking out time and sharing on the topic of clinical manifestations of COVID-19 and its outcomes. We would also like to thank Dr. Shobha Lakshmi for sharing with us about the latest effective therapy for COVID-19 and vaccine update. All of these presentations will be useful for us. As the second wave of COVID hits Pakistan, it is very important for the hospitals, the healthcare professionals, and the general public to be prepared for it. As Karachi Adventist Hospital is in a process of making a COVID unit, we felt the need of arranging this symposium and learn from the experts in this area. We would like to thank Professor Jack Tan, Chief President, Asian Pacific Society of Cardiology, for hosting this symposium. Further, special thanks goes to Professor Haroon Babar Aziz from the Cardiac Society of Pakistan for being a co-host with Karachi Adventist Hospital and making this event a possibility. We would like to thank Professor Lee for moderating this symposium and making sure that the internet connectivity works well. I would also like to appreciate our chairpersons, Professor Abdulla Shehab, VP Gulf Intervention Society, Professor Ishtiaq Rasool, General Secretary, Pakistan Cardiac Society, Professor Dr. Khalida Soomro, our cardiologist at Karachi Adventist Hospital, Professor Feroz Memon, immediate past president, Pakistan Cardiac Society, and Dr. Daniel Khan, VP Medical Affairs at Karachi Adventist Hospital. Finally, I would like to appreciate and say thank you to Dr. Khalida Soomro for coordinating and organizing this symposium. And I thank God for this wonderful symposium. May God bless all of you and keep you safe. Thank you.
At the very end, we also like to have President of the Pakistan Cardiac Society, Professor Haroon Babar Aziz, to give us further comments on this whole session. Dr. Aziz.
Hello, yes, Dr. Haroon here. Can you hear me?
Yes, we can hear you.
Yes, thank you very much. And I apologize for joining late as well because I was involved in a hospital meeting. I'm sorry for that. But I listened to more than half of your program, and definitely it was worth listening to the presentations made by worthy presenters and the participants as well. And we learned a lot about COVID in the last 1.5 hours. And I feel that this is a disease which nearly involves all the organs of the body. So we are not limited to only, this disease is not limited to only one organ. So we should be very careful in the coming time. And as we have learned in the last 1 year, which I will call a very small period of time, in which we have learned a lot of complications caused by this disease, and how this disease changes according to the circumstances, according to the seasonal variation. This is very important to keep in mind, that in countries which have cold weather, it is more devastating. The complications are more devastating there. And the countries which have a very warm summer, in those countries, like in Pakistan, the complications were less, the death rate was less, the morbidity and mortality was less. So of course we are still learning, in a learning phase, and we will keep on guessing when the vaccine is being launched, and we hope that it will be launched soon, and the misery of the world suffering from this devastating disease may come to a halt. Thank you very much.
Thank you. Thank you for Dr. Aziz's closing remarks. And thanks for all the participants of the chairpersons and also the speakers to contribute to the interesting symposium on COVID-19 in 2020. Thank you all and goodbye. Thank you.
Thank you and goodbye. And
yeah.
have a nice day.
Bye. Thank you.
Bye-bye.
Yeah.